Good morning, good evening, good afternoon, everyone. We welcome you today. Thanks for joining us for another episode where we are going to be talking to one of our global experts. Uh, Today's episode is very interesting and very intriguing for my own self because this is a topic we have barely heard about. We may be in the field of mental health and neurological health and care for seniors, but this is a topic which is something really new, I feel, though it has always been existing, but a research and a new point of view has been discovered by our guest who will be joining us today. From the side of 50 Plus Assist and Elderly Care India, I welcome you all. Baton on to you, Pankaj, my co host.
Thank you, Dr. Mrigna, and a very early evening, well, very late evening for you, and Russ, again, a very good evening to you. It is a pleasure to have Russ Barker from all the way from Kansas, USA. Russ has been a long-term care administrator for almost 25 years. And over the period of time, he has understood the need for seizures in dementia, which is again a very specialized subject because we don't come across such in-depth aspects of dementia. Russ has faced seizures in dementia care within his family, and that is where he realized that there is hardly any research which happens on it. We have research on seizures and we have research on dementia, but as a part of a combined impact, he realized it's not there. So that is where he has become a doctoral candidate in health sciences, and he is doing his doctoral in dementia, in seizures and dementia. Russ is also he's also the founder of Seagull Health, which helps assisted living and senior living facilities in identifying, documenting, and preventing neurological impacts of people. Because as per him, a lot of times this neurological effects are misunderstood and not related and because everyone thinks it is dementia, but neurological impact affects in different ways. He's also the creator of uh, Seizure Safe, which is again a platform where a lot of senior living operators and other agencies can benefit through his experience. So, Russ, thank you very much for coming on the session, and we really look forward for learning from your experience and guidance.
Well, thank you for inviting me. It's an honor to be here. I'm looking forward to the discussion as well. So thank you.
So, Russ, I've been very keen and we've been very keen to know about the topic that you are doing your PhD and your doctorate in. And for me, if I'm talking about a seizure, I've been thinking of a moment when someone felt off, maybe very blank stare, unexplained falls, maybe a few minutes of silence followed by deep exhaustion. And people usually in the care scenario take it, oh, it's just dementia. It's just
Right.
dementia happening. So today's session, I really want to question these assumptions that we have made and not with fear, but with compassion. So, starting with the first question that I am really inquisitive to know about, what is actually the Caesar risk we have been talking about in dementia?
I think the key point, like you said, is that we need to think of those symptoms and those signs in a different way. And they're very common. When my mom started developing seizures, it was not something I expected at all. I never was trained on it, never went to a seminar on it. Yeah, I was familiar with dementia in terms of operations and behaviors, but I it kind of blindsided me, to be honest, and I could not find any answers. So I think we typically think of dementia as a memory issue. And what
Very true.
I discovered is that there's a whole nother layer to this, and it's not always, um, the memory issue that we think of, and those things come into play when we think of a brain, as having electrical activity. So, if we think of a seizure, most people will think of the convulsive seizures if you see somebody on the floor. And what I did not know was that they're all different types of seizures and very subtle, very, um, like you said, that can be passed off and just thought of as another stage of dementia or another progression, or, oh, that's, he does that all the time, or, that's just her way of doing, that's just, and my and this has evolved over the last couple of years in terms of my research and discovering this, that there are these subtle signs that if they're not so much addressed but observed, we're not asking for diagnosis, but what we're asking for is, um, what you see is what you document, and you and what whether it, like you said, whether it's, and don't just pass off the lip smacking, the picking at the clothes, the staring off, and all those, when taken in context, is what provides the full picture. And then we can, and that's where the data collection comes in, is what is not out there, and that's why the research is so. Um, there's so many holes in the research. We can't find a specific path to, okay, these signs mean this, or it's just not there. And that's hopefully why I got really interested in the dissertation topic is, um, not only subtle seizures, but there is no risk assessment stratification tool that exists. I've asked many people all over the world, and then we think of a fall risk assessment tool, we think of a mini mental exam that we can score. There is no tool that is currently in place to do that for any country that I have come across. Um, so my dissertation motivation is, even though I can't do a randomized clinical trial, so to speak, I can create the framework by which others can use that as a platform and a foundation if they were wanting to take that and build their own tool, or use that to develop a clinical trial. But I mean, there are different factors that are out there that, you can start to make up your own scoring system, but the data just hasn't been collected. So that is a huge gap in this area. It's just the data's not there.
Very
So
true.
that's very.
And yeah,
Mhm.
sorry, Mrigna.
No, absolutely. No, I was saying, yeah, that's very true. In fact, and same thing, no, the data isn't there. And so essentially what you're saying is that it's not that we miss a seizure because we don't care or anything like that. We miss them because they actually don't look like what we expect them to be, because we don't know the signs and symptoms. And the
Right.
most importantly, there is no data or test battery to help us, to support us, or to help us understand what to expect.
Correct. And I think um, I think the important point here is whether it's a community setting, whether it's caregiver setting, whether it's actually a in the U.S. a regulated nursing home type setting, or another, that it's not adding another tool to what already is in place, because it's certainly not something we want to add to the staff's um, responsibility necessarily, but it's looking at it from a way of a different lens. So the analogy I give is, if your profession is a certain trade, let's say an electrician, let's say, that's all you've done for 40 years is you're an electrician, you build houses, you wire houses, you repair, wherever you go, that's what you see. So you see everything from an electrician lens. And I think that's the point I want to get to, is if we see whether it's family members, people we're caring for. If we have that lens of, okay, now I start to see those little signs. And if I know the history, okay, her mom had seizures, or there's a past brain injury, or they're on these medications, and I'm starting to see those signs, then we can start building the case to give the information to the clinician to then troubleshoot what type of neurological condition is. It may not be a seizure related, but it may be something else. But we can't do that until we have, again, that information.
Very true. Very true. I think yes, as per your research and as per your vision, it is very important to create these tools and which can help identify and document and obviously be preventive on this part. So my next question to you, Russ, would be what was a driving force which made you get into seizures and dementia? I understand that yes, your mother was facing this issue, but was that the only driving force, or otherwise, in your experience of long-term care, you realize that yes, there could have been a lot of cases which as a service provider in assisted living or in kind of independent living, people did not understand. And secondly, as a caregiver, what were the challenges which you faced when you realized that this could be a seizure in a dementia kind of concern?
Yeah, it started. Actually, I would go to doctor appointments with my mom, and one of them was a speech therapist appointment. And that first opened my eyes to the neurological aspect of just Alzheimer's and progression and what is involved. I never really thought of the speech part as also being a language. Speech language therapist is, I never thought of the language piece. As an administrator, we had residents that had speech therapy, but it was typically a swallow study evaluation after a stroke, learning how to speak, learning how to communicate. But I became fascinated with the neuroscience behind what is going on. What's happening within the brain that leads to these steps of increased. Okay, now she's not speaking. We're trying to understand her is what motivated that, and um, that never really, the speech therapy really never went anywhere, but it planted a seed that I actually started as a master's in neuroscience. I went about halfway before I transitioned to a doctorate, and the I just became fascinated with how the brain works, and I think if and actually, what's interesting is the type of subtle seizure, whether it's verbal, whether it's like an oral automatism or more of a motor, that can indicate the part of the brain that's affected. Um, if I can just go down that path a little bit, the one of the characteristics that my mom had as her disease progressed was that she would repeat words. And at the time, I just thought it was okay, that's her version of Alzheimer's progressing. But now I saw that as a precursor to what she was ultimately going to face. Um, so it would words like man, 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 can. She would repeat those all the time. And again, I just brushed it off as, well, that's mom. That's but now that I understand, and that's where I got to thinking about the framework of trying to at least put names to the seizure, this spectrum. And if you go to my website, I it's one of those things that came to me as I was doing my research is this dementia seizure framework that to explain that it's not just a convulsive seizure. There are not so much phases because not everybody's going to hit every one. Um, just as if some people who have Alzheimer's don't always go. I mean, there are steps, but it's not always consistent across each person. So the idea that we can um, if we that's another piece of this puzzle. If we can start identifying those traits or characteristics, I would have intervened a little bit sooner versus reacting to the full-blown convulsive seizure that she had when I woke her up one morning. But there, in between that, there's also the myoclonic episode where you start to twitch. And I thought she was being startled by something. I did not know that was another precursor to potentially a full seizure. So all these things stacked together. I never saw those, never noticed those as an administrator. So to get back to your question in a long-winded way, I kept thinking back to how many we just never thought of it. We never and the motivation. I put my administrator hat on, and I think all the falls that happen. We think of a fall as being the beginning of a story. Okay, a resident fell, or my mom fell doing this, or walking out to the car. We think of that as the beginning of a story. Then we start to, okay, something's happening here. My perspective now is that's the end of the story. The story begins much sooner.
That's correct.
And so those staring off in the space, or the blank, can't coming up with words. How many found on the floor falls happen in communities? How many you just unobserved, they're going to wake up somebody in the morning and they're on the floor. You don't know why. I think those are what motivated me to, I've got to get this information out to at least start the awareness, start the education, and prevent those. Because my mom had those too, and I can think of all kinds of falls that happen as an administrator. I mean, that was one of the, in terms of regulations and citations and fines and lawsuits, falls are probably right up there as top one or two that it puts my license in jeopardy.
Correct.
If those happen too often. So it's initially became personal, but then there was about a 16-month gap between when my mom died and then I started Seagull Health. And in that time, I started to realize of the journey I went through, and then other people need this information, because if I can't find it, it's very likely that somebody who's not even been in healthcare can't find it, or even the doctors have never thought of it. I mean, I've spoken to many doctors, MDs. I have a presentation in the morning to a group, PhDs in neuroscience. It's not talked about. And so I think at this point, we don't know what we don't know. But it has become, you think about, you look back and things happen for a reason. And this is my way of honoring her and getting, hopefully helping somebody else that, at least understand. Obviously you're not going to prevent, you can't stop Alzheimer's at this point, but at least if you have the information to understand it, it can give you some peace a little bit and some ammunition to, okay, we can try this, we can do this, and go to the doctor with, these are my notes, this is what I see, advocate for, okay, and maybe some intervention. So
No, I can totally relate with your experience, and in fact, that is why when you were saying, I was just trying to figure out. A lot of times, when my father is trying to get up from the chair, he gets this vertigo, and generally doctors, normal doctor physicians would say, "Oh, you have sodium problem, you have this problem," And
Yeah.
then a lot of times he will fall off from the bed and he's not able to get up, or from the washroom when he gets up, because he feels lost. So I'm just trying to think, it could have been a trigger of a kind of a seizure which is repeatedly making him do that. It cannot be a regular fall every time
Right.
and so often. So probably yes, that is something we'll discuss offline as to if any kind of data you want to capture, which I can do, because he keeps saying, I think I'll be getting dementia, so please bear with me for those period of days, because he himself is 87. Though he being an army veteran, he is quite strong mentally. But then
Yeah.
obviously you can't fight your physical ailments or the physical health after a certain point. So definitely, I think it's what you're saying. I can totally relate to it. Very true.
Yeah.
True, Pankaj. I think also the fact is this is so important because it's just not about the documentation part of it or just the paperwork of it. It's actually the advocacy. And especially for individuals who cannot speak for themselves. It is super important because in dementia, they may be having an issue, they may be going through seizures, they may be going through a lot of things, but they cannot talk about it. They cannot explain about it.
Right.
So I think this documentation is super important and it has a very big importance in the coming days. I think we'll know more and more as we'll study more about these things. So let's talk now, Russ, practically what you suggest for people, especially like caregivers or families or professionals who are watching us today. What signs or what key signs do you think they should pause, pay attention to? What are some things that they can let go, and what are the something they should hold on to and not consider it just blatantly dementia?
Well, I think if I refer back to why I developed SeizureSafe is kind of categorize a way of progressing through. And I think the first step is to recognize, like you said, is to be able to have the knowledge to recognize that um, what is happening, and be able to understand that if you are going to, because it may be something that it is not related to seizure, but I think we're not going to know that until we have the information, the history and the medication history and all those things that come into play. Are they sick? Are they not sick? Are they running through an infection? But I think if we focus on the recognition, um, I think the most important point is that we're not trying to diagnose, and um, it really is figuring out what the baseline is. And I think where we can bring in neurological disease as a whole, some of those different diseases can be difficult to distinguish. Parkinson's, for example, can be one that's okay. Well, if I say look for twitching, well, my dad twitches all the time, and um, but I think the most important point is everybody, no matter what it is going to have a baseline. And I think the key with that is if we identify the baseline, and the patterns, it's not so much what happens today or this hour or this morning. It's over time, what
Very
is the
true.
pattern? If we have a baseline, then if um, what we've talked about as a subtle seizure or a subtle event, if they do stare off, and is it a long term? Do they kind of, and that is that their baseline? That may be because of a medication issue or a lab issue, or blood sugar and all different, potassium, and but if you recognize the baseline may be normal, the baseline may be just a rough day every day, and that's just because of the disease they're going through. But something happens, and then how quickly do they come back to their baseline? If that happens, you're more inclined to think of it as a seizure related incident. because typically what happens in those events is that um, if they come back to whatever that baseline is, but if it is a long term that you don't see that bounce back, it may not be related to a seizure. It's more of something else going on, or just it could be obviously a multiple things. But I think that was really interesting to learn, because I struggled with that as well, and all the different types of neurological conditions and even the different types of dementia, because each one manifests differently. I
Correct.
mean, Alzheimer's is just one piece, but there are how does vascular dementia, and quite honestly, the research is not out there to provide that context at this point. There's a little bit, but that's another area that just is not out there to provide. But I think the most important thing is knowing what's the norm. Things may happen, but if they bounce back within 5, 10, 15 seconds, that something may have happened there. That may be more of a seizure related incident. Um,
Okay.
so does that answer your question somewhat?
Yeah, actually it does. It does. It answers a lot of things and leaves me with furthermore questions. The more you are explaining, the
It's
more interesting it is becoming, and the more questions I have. So, for example, we just spoke about the seizure risk, and does it changes? Let's say we spoke about Parkinson's, or let's say other things like neurological disorders, maybe motor neuron diseases, or delirium, or anything else. So, does this seizure risk the changes? Of course, we spoke about the baseline of being different and how fast the person is coming back. But how about the risk assessment of the whole? Does it changes?
I think it does. Again, I'm going to keep coming back to this, but this area is so new. It is tough to find information from which to get some type of risk assessment. Um, the I mean, I've put together different versions of risk assessment tools. They are they're not clinically validated, but it's based off of the database that I have, and kind of pulling in. One may not be the exact population that you're looking for. You may have been like military veterans that are in a hospital over the course of 5 years. And that's a very specific population, but it's tough to extrapolate that out to the whole, to start making a whole, but it's valuable information. And I think what it's becoming more accessible to find out um, genetic risk. That's a big factor as well. If you do have, the ApoE4, which I have one copy. I don't have two, but I have one, so I am at a certain risk of not only Alzheimer's, but the seizure related. So the family history is a big one, um, but if you can capture the genetic um, makeup, that's a big player into um, obviously the seizure risk. So it's tough. I think again, I'll go back to how I would approach it is you take each disease or neurological condition and really hone in on that particular disease and what is like a clinical pathway for um, somebody, the Parkinson's development over time is even though the speed may vary with which you progress, but there is a pretty set stair step what conditions start to happen. And I
Correct.
think
You know what to
when
expect actually out of it. That's
right,
very true.
but you have that pathway, and then um, you have that foundation from which you can start evaluating any deviation from that, and that starts to narrow down your focus of, okay, well, this isn't the normal quote unquote Parkinson's progression. Something else is going on here. And then you
Great.
start to put the pieces together of everything else. Um, and again, if you have that education of that lens from which you look at things, um, that at least raises the question of, hey, let's look at this. Or I need to bring that up, like you said, to advocate for, okay, you said Parkinson's is going to do this. Well, I'm seeing this. So I would like another, consultation with a specialist that, a neurologist or whoever you need to see. Um, but I think it is about, understanding the disease and what that typically looks like. What we haven't talked about is, and I think the exciting piece of this, and I won't jump ahead, but I'll kind of tease this. If you want to get to it later, that's fine. But all this is, there's a lot of uncertainty. But I think the exciting thing is that if we flip the strategy on its head, we don't think of, we typically have thought of seizures as the end. Okay, this is something that happens at the end. And this is
Great.
just another piece of this that, we're getting to the late stages and it just happens. But if we understand the mechanism by which this is happening, we flip this from a, kind of a, not so much giving up, but okay, we just resign ourselves to, oh man, she has seizures, but I could have intervened 2 years earlier. And to me, that's exciting. That's the exciting piece, is that uh, we can we're giving families and care teams information from which um, we can attack it in a whole different strategy and approach Alzheimer's progression and different dementias from a whole different perspective, and not just trying to find another medication, which do come into play and are important, but there are all kinds of other strategies that we can do to help, nutrition being a huge piece of that. Um, and that was actually going to be my other dissertation topic, is the gut-brain axis and how it relates to cognitive decline. So
Oh,
my
yes.
concentration and my doctorate is actually clinical nutrition. So there is going to be a piece of my dissertation that focuses on the nutrition aspect of all this, and not
Yeah.
just, we have a seizure, okay, we need a medication. I mean, the body can, if we understand what's going on, we can allow the body to heal in a certain way, um, that at least it's not going to cure Alzheimer's, but it's going to slow. It may slow this progress, and to me, that's an exciting piece. It's hasn't been thought of. It's we're kind of turning the whole, we're flipping the script, so to speak, and um, to me, that's. But again, we need the data, we need the research, we need the understanding. So.
No,
No, that.
I totally agree with you, Russ,
Mhm.
that there is a lot of work which has to be done in this the field. And so, as an extension of what you explained to us, I wanted to understand how prevalent, in your experience, because you have been studying this subject for some time now. So, what is the kind of a prevalence you think would is that, especially the seizures and in particular with the dementia, is there in the long-term facilities as well as in their own homes? Because though I understand the data is not there, but I'm just saying, as per your estimates, because you have seen it firsthand, I'm sure there would be thousands of other families also who would be going through the same situation, but they've not been able to identify this particular issue. So, as out of 100, of what percentage you think would be having this kind of thing?
Well, there are research about prevalence. There's some. They're just depending on the study, depending on the paper you look at, it just varies. So when you start to see such a wide range of percentages, then in terms of developing clinical protocols, it gets a little tough, because from a physician standpoint, like, well, you're giving me a huge range here, and I don't know how to attack this. But how I how I explain it is, let's say it's a community with 100 beds, and it's a memory care. They're all there for a reason, of different types of dementia, different types of neurological conditions. Um, about 20% of those are going to have a seizure at some point within a year. Now, it may
Very
not,
high
like I said,
percentage.
it may not be the full convulsive seizure, or where you, and the thing when those happen, and that's, even though we're talking more about subtle seizures, but if you understand the what happens during a seizure, you don't always have to send them out to a hospital. So you protect the resident; they don't have to get transferred, and then that whole change, you know, throws them off. They're confused when they come back. If they come back, a cascade of effects. The staff are, it takes time away from other things they need to do. But yeah, roughly about 20%. If you look in a community, so when I speak, when I spoke at a conference, there's a room probably about 50, and I had them, okay, this table over here, you're going to have a seizure at some point in the next year, and just to try to drive home that, okay, it's not everybody, but that's a big percentage. And for me as an administrator, if I know 20% of my population is going to have at some point a seizure, which more than likely in some way is going to lead to some other incident, whether it be a fall, whether it be, whatever, choking, trying to eat, or um, if I can save just a percentage of that percentage, I'm going to, that's, that's going to help me. It's going to help my staff. It's going to help the residents, help the family. And then the families are more confident that, okay, this place really knows what they're doing. Um, So yeah, I have three hats. One is the long-term care executive hat. I have the researcher hat, which I go down these rabbit holes and investigate, how the brain works, where are all these, what's the data say, what's the research say, and then there's I even though I'm not caregiving anymore, but there is this family caregiver hat that I still hold, and so it's different when you've lived all those different roles of um, I got to where I could see a seizure coming on. I knew when I needed to back off. I mean, you see it in the eyes, at least with my mother, and it may present differently for everybody, for other people, but once you start to see that, um, it takes on a whole different meaning. And so it is something that it's it's impactful enough that it can, my soapbox to long-term care executives, it can fundamentally change your operation if you take it seriously. The challenge is that we don't know what we don't know at this point. So they don't see it as they recognize that falls as an issue. They recognize that these things, but that's the outcome. They're not looking at it from, oh, if I can save 5 falls a month, you know, but they don't know what they don't know, because they haven't been trained. They haven't been, and I wasn't. I mean, I'm in that same boat. I did not know that there was a connection. So I never would have taken it seriously. It was like, I have 20 other things that I'm responsible for day to day. I'm just trying to get staff in the building. And, um, but it's significant. And I think it's going to even get more significant the more people, as we recognize what really is happening, and not just dismiss those signs. I mean, I talked to enough caregiving dementia groups. Um, I'm just joined the advisory board on the International Caregiving Association, and I, I still, I asked the question: have you seen this? Have you ever heard of this? And I know you're the first person I've talked to about seizures, and I just, it floors me. And um, whether I make it work or not, at least Somebody else may take the baton and take it farther than me, but at least I'm starting the ball rolling down the hill. So, but it's significant.
No, it is, Russ. In fact, about caregiving, when we're talking, it's true. I mean, it's like being in army. So once you're in army, though you may retire, but still you are part of the army. Same goes, I feel, for caregiving. So once you're a
Right.
caregiver, you may not be an active caregiver in your life, like another moment, but you still have this heart of caregiving. And this is why I see a lot of people who have been caregivers themselves are the people who have come forward towards initiative and working in the field, because trying to solve first the issues that they had. So I personally also started very similarly, where I started with my own grandma having dementia, and we moving out of options in India, understanding what can be done for somebody with dementia. And I totally understand when you say essentially families or caregivers watching are often with this kind of a guilt when they understand, oh, this was probably what was happening. So probably now that you're talking, I could feel a lot of times when my grandmother would go just blank, and then it should be exhausted, she would be tired,
Yeah.
and not like you said, not coming back to her baseline. And people also are then, I feel, full of guilt that they feel that did we miss something? We could have done something better. We could have done something, but the truth is that we weren't taught to look for it.
Right.
And we cannot be responsible for something that we are not even taught to look for, right? So I feel this whole talk, this whole awareness is very important in terms of people understanding that, look, this can also exist. This can also be the case. Though we are not committing and we are not diagnosing anyone per se, but yes, a clear possibilities needs to be shown. And I think the more data we'll collect on it, or more case studies we'll have on this, will move the things more further on. So coming to the case study part of it, I understand that your first case study, or the first thing you observed, was your own mom, and working with things around her. But apart from that, since you've been also be very actively working in the aged care sector and people with dementia, can you share with us, like, a case study or a story where that stayed with you, and that really truly showed you the impact of recognizing the risk of having seizures? So this is something I would really love to know.
I think I'll take a little bit different angle to your question, if I may. Um, I'm actually going to be starting with a group, um, my alma mater, for my master's at University of Missouri. Um, I'm actually leading a group of students that we're going to start investigating um, in communities uh, what the impact would be. So those issues I wrote, I brought up that the how many falls, how does this affect workflow, and how many times do we send residents out because of a certain incident, and what the impact can be. So it's not so much a case study as if I were to describe a relative, but a case study in the sense that workflow analysis and the impact of how this could affect operation hasn't been done. So we can start to answer those questions of, okay, how is this going to help me, or our operation? How is it going to help our families? And if we can provide um, to start identifying those communities that become uh, I mean, in my dream, I would love to have like a SeizureSafe certification for communities. So based off this, we can give them the tools and the framework that they can implement. That's not going to add and interrupt operation, but it becomes a case study in that we're going to start to get to some answers, and then within that, we can provide kind of this. I'm always looking for the clinical pathway in whatever happens. So, can we start to design a standardized framework by which we we can put pieces together of clues and then over time demonstrate that this is the impact? It's tough to do right now, but I'm hoping that that project becomes something that um, can again fill a piece of that puzzle. So I answered it in a little different way, but that's the first thing that came to mind. But there are, I think the key part is um, that families will start to notice changes, and then if we can have families notice changes, care teams notice changes. Um, so the initiative has become focusing on the educational aspect of all this, and also create this shared language where we can just start describing whether it is so we know what we're talking about. Right now we don't know what we're talking about. And so if we can create this shared language of because the problem really is universal. I mean, dementia, whether it's in America, Africa, India, I mean, that's dementia is dementia. It's not, you're not immune from it. I mean, yeah, there's different cultures that approach healthcare differently, and certainly, we can go down that path, but that's a whole nother can of worms I actually started my doctorate in global health, but I'm just fascinated by the differences and the ways that different countries approach aging, and it's just fascinating to me. But um, so I would say the again, I'm kind of going off course a little bit, but the gap really isn't an awareness of dementia. I think the gap is what else may be happening alongside that disease path. But and I think the data is going to be more provocative than people even realize, and that's the part that's exciting for me. So
No, it's I think very interesting, Russ, that this has been a very insightful session. So from my side, as a concluding thing, I totally stand by your vision, because probably 30 years back, even dementia probably would have gone through the same learning curve,
right,
especially in India, because eventually, without research, you can never find a solution, whether it is the medical solution, or it is the health solution, or it is the caregiving solution. So I think what you have started is very pioneering, and the results will, I'm sure, will follow in the coming years, because more people will get interested and more people will identify with this particular symptom. So I really, really appreciate all your knowledge and all your inputs. So thank you for coming on the session, and I'm sure probably after a few months we will revisit this thing and see what the developments are. So from my side, uh, thank you very much, and really, really appreciate it. Mrigna.
So, yeah, on behalf of Elderly Care India and 50 Plus Assist, we really thank you, Russ, for reminding us that safety actually begins with this curiosity and compassion, which is very important. So, for everyone who is watching us today, your presence here makes you the part of the solution. Let's continue asking better questions, because when we see better, we care better. And this is the reason we are here. Thank you so much, and wishing you all Merry Christmas and a very Happy New Year.
Yes. Very Merry
So, see
Christmas to
you.
you, Russ.
thank you. Thank you. It
Take
was
care.
an
Thank
honor
you,
to be
everyone.
here, and it's like I said, it's exciting, and we spend so much money on Alzheimer's research and medication, and finding the new drug that's going to cure it all, and um, I think this is a new strategy, a new approach that's exciting, where we don't it just, this might just be the kind of a new frontier in terms of this research. So I thank you for the time and asking me to be on and kind of get the word out, and hopefully it'll help somebody and trigger a conversation, some investigation of their own, and maybe help somebody. So thank you
No,
again.
we're very sure that it will help a lot of people, Russ. So thank you very much. Thank you.
Thank you.
Right.
All right.
Thank
Okay.
you.
Thank you.
Bye-bye. Bye.
Bye.